So for the next talk, I would like to invite Dr. Harsha P. She's he's oh she's the AIOS Nursing Raw Award winner. Uh, she's going to talk about an important topic, that is the sarcoidosis tuberculosis conundrum, the role of serum ACE, Montuxtex, and lymphocyte count. Over to you.
Good morning, everyone, and thank you for the opportunity. Ocular tuberculosis and sarcoidosis are two diseases with very overlapping clinical features, and hence differentiating one from the other is a challenging task. Now, they are even postulated as opposing presentations of the same disease spectrum. Even though conventionally serum is seen to be elevated in sarcoidosis, there is a lot of overlap, and also sensitivity and specificity of serum ACE, MAN2, and lymphocyte count vary in different study populations. So the studies depicting their utility in combination are scarce and are quite relevant in TB endemic countries like India. Now, the purpose of the study was to evaluate the diagnostic utility of serum ACE, MAN2 test, and lymphocyte count, both in isolation and in combined, in the diagnosis of ocular tuberculosis and sarcoidosis. The outcomes were sensitivity, specificity, positive and negative predictive value. This was a prospective observational study which happened for 2 years in UVA clinic of Aravind Hospital, Pondicherry. We had 95 patients with acute uveitis of age more than 18 years, and we excluded patients with history of trauma, immunosuppression, and patients on ACE inhibitors. Now, the diagnostic criteria used was revised IWOS criteria for sarcoidosis and the Gupta et al. Criteria for ocular TB. We had 95 patients with a mean age of 44.52, and out of 12% of the total study population had ocular tuberculosis, and 20% of the study population had sarcoidosis. Now, serum ACE was found to be elevated in 89.5% of the sarcoidosis sample and only in 33% of the ocular TB patients. Now, the mean value was 76 in sarcoidosis and 50 in tuberculosis, which was statistically significant. MAN2 was elevated and positive in 58% of the ocular tuberculosis patients and only in 15% of the sarcoidosis patient. The mean value was 12 in TB and 2.95 for sarcoidosis, which was significant. Now, lymphopenia was seen only in the ocular sarcoidosis group, and none of the other groups had lymphopenia. Coming to the sensitivity, specificity, and the predictive value, elevated ACE had a very good sensitivity and negative predictive value in diagnosing ocular sarcoidosis, and also negative MAN2 test also had a good sensitivity and negative predictive value. Since we had only one sample with lymphocyte count less than suggestive of lymphopenia, the specificity and PPV became as high as 100%. Now, in ocular TB, non-elevated AC and elevated AC both had a very good negative predictive value. This was an interesting finding, and also positive MAN2 had a very good negative predictive value in diagnosing ocular TB. The ROC curve for sarcoidosis for serum ACE was 0.819 and was statistically significant and better compared to that of negative MAN2 and lymphopenia. And for ocular TB, the positive MAN2 had an AUROC of 0.835, which was significant. Coming to the strengths of my study, this was a prospective study where screening was done by a single trained observer in a single tertiary eye care center. To the best of our knowledge, no study conducted so far tested the combined utility of elevated ACE, negative MAN2, and lymphopenia in the diagnosis of ocular sarcoidosis. The study also analyzed the utility of serum ACE in ocular TB. Now, coming to the limitations, this was an observational study without any randomization, and also study period included the peak phases of COVID-19 pandemic, so viremia due to coexisting or previous infections could have affected the lymphocyte values. There were no biopsy-proven cases. Subjects included were presumed or probable sarcoidosis and probable or possible ocular TB. A similar study by Ilangar et al. From South India says elevated ACE was an independent risk factor rather than this in combination, but a study by Philippine Court et al. Says combination improved the diagnostic performance. So the day clinic message is combination of elevated ACE, negative MAN2 and lymphopenia had a better ability to diagnose ocular sarcoidosis owing to high specificity and positive predictive value than these tests in isolation. As the NPV is very high in subjects with normal ACE, further screening tests for ocular sarcoidosis may be required only if clinical suspicion is high. Even though serum ACE was elevated in some patients with ocular tuberculosis, it may not serve as a useful screening or diagnostic tool in the detection of ocular TB. as the NPV is very high, in case of negative MAN2, further screening investigation for TB may be necessary only if there is a strong clinical suspicion. Serum ACE level assay is a better test for discriminating ocular sarcoidosis cases from the other diagnosis, and MAN2 test is a better test for discriminating ocular TB from other diagnosis. Thank you.
That's a very nice talk. Just have one or two questions that I have for you. Number one is, what's your take on CECT or HRCT while differentiating between sarcoidosis and tuberculosis?
So HRCT would be an ideal investigation where we see bilateral hilar lymphadenopathy, but for our population, like those people who are willing for HRCT, we had relied on HRCT, but there were a few who are like financially not viable to take an HRCT, so we took chest X-ray instead of HRCT. But also the bilateral hilar lymphadenopathy documented on chest X-ray. CECT would be a better, it's one of the diagnostic criteria in IWOS, and in they mentioned HRCT as one, bilateral hilar lymphadenopathy and HRCT as one criteria for the diagnosis.
So solely relying on the ACE levels as well as the MANTOX, you're right that MANTOX is because of the energy that happens in sarcoidosis. The MANTOX is usually not that high, or it is non-reactive.
Yes.
However, in a cases of tuberculosis, although we are in endemic region of tuberculosis and we have been all vaccinated, so it usually don't go up beyond 15. So if it is more than 15, it is probably you're looking at TB and not a sarcoid patient.
Yes, sir.
And if you have an ACE, so what is the ACE level that you have found to be cut off for your study, that this is doubtful ACE and this is
We took the
confirmatory ACE?
cutoff as 52.
Okay.
The main reason for this study was that there's this new hypothesis saying tuberculosis and sarcoidosis to be the part of its spectrum, where Mycobacterium tuberculosis is also the etiological agent responsible for sarcoidosis, especially in endemic countries.
Okay.
So the study states that they propose that in endemic countries like India, patients with ocular sarcoidosis might have Mycobacterium tuberculosis infection in a latent fashion, but because their immunity is very high, they don't have features similar to that of the ones with ocular tuberculosis. So that is why we wanted to test whether there is an overlapping pattern. So we conventionally we think ACE is elevated in sarcoidosis and MAN2 is like negative in sarcoidosis, but we could get samples with positive MAN2 in sarcoidosis as well. So we think there is an overlap as well.
But I think doing in CECT in these patients is going to be the more diagnostic,
Yes,
rather
sir.
than
Definitely.
these tests itself.
Definitely.
Thank you.